Okay, good morning. Today we're going to be talking about the various associations of kidney diseases with HIV. Unlucky for me, I just gave this lecture like a month ago, so so it was good timing. I start with a case presentation. It's a 44-year-old Caucasian male who with HIV who has been treated successfully with the medications. He visited his primary care physician because of progressive fatigue. Physical exam as well as his vital signs have been unremarkable. No nausea, no vomiting, fevers, no diarrhea, rashes, no headaches, no shortness of breath. Basically no negative review system except with the fatigue. And his HIV has been very well controlled and is very compliant. Actually, these cases are from the VA. Sometimes I change a little bit the age or whatever, at least make it. But actually, there are cases that we have seen in the VA. When he got a BMP, it was remarkable for a non-anion gap metabolic acidosis with a low phosphorus. Both of these findings actually have been new. These labs were repeated, so they were accurate in comparison to his previous labs. His urinalysis revealed glucose, but this gentleman has never been diagnosed with diabetes, and a hemoglobin A1C was normal. Therefore, based on this clinical scenario, does anybody wants to take a guess as well, or an educated guess as to what may be the explanation for his situation? Yes, exactly. Fanconi's. That would be correct. That would be number C. Even though when we're really tired, we pick E. Just give them a carbon and go to the next patient. No. And of course, I didn't mention what was his regimen on, but of all those medications that are listed in there, which is the one that unfortunately gets sometimes a bad rap. Because of its association with this situation is Tenofovir. Yes. And actually in this patient, he has been so well controlled. That's why sometimes these situations are difficult. Obviously for the infectious disease expert, and for the nephrology, because obviously we don't like to tell you change your regimen, just especially when it's been working so well. So sometimes, for example, in that particular case, what it actually happened was it's very hard sometimes to estimate the true GFR, and we'll go a little bit later after this case on that area, because sometimes, of course, we use serum creatinine for that, but you have to look at the person's body type in terms of muscle mass. Sometimes you may have to do a 24-hour creatinine clearance to have a more accurate GFR. And actually, in his case, we just adjusted the dose based on perhaps what was his actual GFR. Because he was a very thin-looking male. Things actually turn around. He stabilized. So sometimes that's you don't have to make an overhaul change. It's just some fine-tuning. This is another case presentation. The 38-year-old African-American male presented to his PCP for a routine appointment. No complaints. His labs, which were about almost 9 months prior to this his visit, when compared, reveals a new anemia. He was normal before, and reveals a new anemia, and also a creatinine of 4.0. Prior to that, it was 1.2. He was completely asymptomatic. He actually was from the Orlando area, and as a result, we send him here to get admitted. It's difficult to work it as an outpatient from that distance. And the only basically new finding was in terms of the virus was the high blood pressure, which can be attributed to his renal dysfunction. Otherwise, his physical exam was unremarkable. The UA did show 10 grams of protein when we quantify the proteinuria per gram of creatinine. No RBCs, no whites. And his albumin was low, and his LDL was elevated. So basically a nephrotic syndrome type of picture. Obviously, now we know, there's a lot of association with HIV and kidney disease, so part of his workup entails doing the HIV. And nowadays, it's a little bit easier. We don't have to do the consent, just telling them, which is actually has made it better, to get more people screened. His CD4 count was 222. Viral load was 360,000 copies. And during his hospitalization, it continued to deteriorate the creatinine. But because it took some time by the time he actually showed up to the hospital. That's why we had to call him several times to really make him come. So they drew the labs in Orlando, but unfortunately the patient took a while to show. And that's why when we actually came to the hospital, his creatinine was 5.2. And now, based on that clinical scenario, what would be, could be perhaps a couple of answers here, could be correct in his case. That's a good question. I mean, we'll talk about that. That's a good suggestion. Which one do you pick? C would be like the most, exactly, I guess, politically correct. Exactly. Obviously, begin treatment for nephrotic syndrome. That could be an ACE inhibitor, absolutely. Blood pressure control. Consider renal biopsy. And your guidelines have changed in the last few years. I mean, now it includes if you find evidence of, if you believe there's evidence of the HIV causing kidney problems, you can start the antiretroviral therapy even before you do the actual biopsy. I mean, that is a legit situation now. If you strongly feel that the HIV is the one causing the problem, just like it would be like any other organ manifestation, you can initiate the antiretroviral therapy. At that time, however, this patient was actually right before the guidelines were not available yet, so we have to wait. I mean, it was still somewhat of a controversy, but that was the trend to start the treatment. In his case, actually, we did a biopsy. Later, I'll show you the picture. It turned out to be HIV-associated nephropathy, and he was initiating with on antiretrovirals. Within few months, I mean, within a month, obviously, his creatinine started ready to come down. I mean, and within a few months, it went all the way down to 1.6 or something like that. So really did well. Really did well. So we're going to talk quickly about some background on the epidemiology of the kidney disease in HIV, screening for kidney disease, a differential diagnosis, and management. I'm going to try to focus mostly on the most practical aspects. I mean, because there's some areas in this lecture that are a little too detailed, more for the nephrology fellows, but for sake of time and sake of practicality, and I'm going to make it, the things that perhaps are the most needed, that we need to focus on. Thankfully, since the introduction of antiretrovirals, you guys very well know that you guys experience this every day, that this population life expectancy has really increased, and basically now we're starting to see actually more of the chronic diseases in this population rather than the diseases associated with the HIV per se. And that has been the trend in management. So basically, the hallmark right now is that you have to take care of the patient just like anybody else in terms of the comorbidities, which are becoming more prevalent in this population. Seems to be increasing in terms of the kidney disease, perhaps because of the comorbidities, and they're living longer. So obviously, you're going to find more problems. Whether there's always been somewhat of a controversy whether acute renal failure is higher in the HIV population as compared to the non-HIV population. That really depends a lot on the comorbidities also the particular HIV patient has. I mean, so in some settings perhaps where the patient have better medical care, that's perhaps not really a difference. In some papers, if this were done down in big cities, for example, in which may have some aspect of the population don't have good access to medical care, then there was definitely a difference. So it depends what you practice. Every time you see a patient, it's important to try to establish if they have chronic kidney disease. That will help you to see if you need to drug adjust medications, and also as to how to manage them according to their stage. Basically, you know, it's not like you have to memorize all the stages or anything. It's just be aware that when you see a patient and you see their labs, if you can compare with older labs, that will help a lot. Try to measure the GFR. Nowadays we use MDRD formula. It's a complex formula, so the best way to actually analyze the number is if you type mdrd.com. It's a website that just plug in the patient's information, and within a second, you know, you can tell a patient's estimated GFR. If not, you can still use the Cockcroft-Gault formula. It's basically just as good. It's just MDRD perhaps is a newer trend. I mean, a little bit more accurate perhaps in population studies compared to the Cockcroft-Gault, but it doesn't matter which one you use. As long as you use the same one for that particular patient, so you can follow the trend, is what's important. In terms for risk factors, in the African American ethnicity is where most of the new HIV cases are being currently diagnosed. Already they have a higher, despite the HIV, risk to develop ESRD than other ethnic groups. It could be socioeconomic factors. Also, there's a lot of genetic factors as well, especially on hypertension. For some unexplicable reason, in the African American population, is harder on the kidneys. And it's also weird because, on the other hand, they last longer on dialysis too, so I don't know what that means. So that's why some of these population studies are hard to interpret. And now these are the things that basically we had to take a look at when we see the patient with chronic kidney disease and HIV. Development of diabetes, management of high blood pressure, smoking obviously, hepatitis C. Many of these things actually you guys already rule out when you initially diagnose a patient with HIV. The CD4 count obviously puts higher risk. If they have any type of behavioral issues or recreation, like such as recreational drug use. And I put in question marks Tenofovir. That because, as I mentioned in the beginning with my initial case, obviously there has been some association with Tenofovir and causing kidney damage, and there's some evidence of that. However, there's also evidence where if you manage the HIV well, I mean, in terms of the viral load, you know, according to you guys' guidelines, the kidneys actually last longer overall. So I put the case at the beginning because sometimes it's just perhaps adjusting the dose what could make the difference, and not necessarily taking the drug away. Because to be honest, I mean, in that patient, the second case that had the high band, he was initiated in tenofovir. I mean, and you would think, well, you're trying medication that's potentially nephrotoxic in a guy that already had kidney failure. It's a little bit of a difficulty, but no, the medication works very well to treat the main condition. You just have to adjust it. And
I wonder if also tenofovir penetrates better the kidney compared to others.
yeah, it does. There are some tissues from, I mean, some studies from rats, and they do studies in trying to identify where the drug goes. It is true. As the drug is definitely metabolized in the kidney, you're going to find a lot of the medication within the kidneys. There is some evidence that the HIV, that the kidney is one of these reservoir organs, I mean, for HIV, like brain and I know some lymph nodes and what have you, reticular endothelial system. Therefore, by having medications that target, in theory, that go to those organs in higher amounts, it may improve that organ's outcome. And it's interesting you bring that because we had a patient. Unfortunately, I didn't put it as part of this lecture. I mean, because it's a little more complicated. But he was already controlled on antiretrovirals. He developed proteinuria. Viral load is undetectable for years. I mean, CD4 counts in the thousands. CD4 is like 1,000 to 1,200. Guy's shaped, I mean, strong. And it showed HIV nephropathy in the biopsy. That was last month. And now we are like, really don't know what to do. I mean, a thought was perhaps making his regimen to tenofovir. It's not in tenofovir, as it may achieve better levels of the medication in the kidney, and that may help. Yeah. But the problem is that at the present time, understandably so, the patient has been so well controlled that he doesn't want to alter his regimen. I mean, we talked to him several times, and unfortunately we have no, at the same time, this is all theoretical. There hasn't been a study whether tenofovir versus something else is better for HIV nephropathy. If you see a yellow man or a lady with HIV, sorry, sometimes I use more the male because I work at the VA. Not because I'm sexist. And if you see the GFR, according to your calculation, less than 60, it is prudent to do a consult to nephrology, at least for a general evaluation, to make sure there's nothing else that could be adding to these patients, comorbidities, and also something that we can reverse. It will be excellent. It gives you more room for medications and things like that. This is, like I mentioned earlier, the formulas. So creatinine by itself is not sufficient. You have to plug in into one of the formulas. I mean, please. I mean, because we see this, unfortunately, I mean, not only in HIV, I'm talking in general. Many medications that are given in higher doses than when they should be, and sometimes they can be done being toxic. So unfortunately, sometimes when the patient is an acute renal failure, that's very hard to decide, because since the creatinine changes every day, then you don't know what's the true GFR, and that's an argument nephrologists around the world have. Like, it's hard to we don't have a number. So in those situations, you have to take somewhat of a educated guess in trying to predict what will be based on how the patient is doing. So proteinuria. Right now, the recommendation is to do like a UA when you see the patients with HIV. You guys diagnose them for the first time, which include the distich. However, I will also add to it even though it's not part of the guidelines, but even though it's actually written in the IDSA paper that talks about the guidelines, that actually there should be a total protein creatinine ratio, random, so you can calculate the protein, because the distich sometimes can miss 20-25% of the time, like it can be like a false negative. Okay, so it's good to do the total protein creatinine spot or random to have a more accurate quantification. If that ratio is more than 300 milligrams per milligram of creatinine, or 0.3, depends on the units that you use, as long as they match, then this person is having a little more a normal amount of protein. It's not huge, but that means maybe a referral or to the primary to do further evaluation. In terms of making sure there's no other associations. One of the most common conditions that actually that we are finding, because population is also aging, is actually diabetes. So sometimes that could be the way to diagnose diabetes, is when you see protein in the urine. And especially now that there's some question with some of the antiretrovirals and metabolic syndrome, that's important to make sure the patient indeed has diabetes or not. So you can obviously treat it. So the most common cause is diabetes. If you find proteinuria, the one that is still the most aggressive, it would be HIVAN. Typically, most of the other causes, for example, are hypertension or a little bit of chronic kidney disease. You can have a little bit of mild proteinuria. And sometimes you look back at the patient's records and it's always been there. So if it's fairly stable, that's okay. But that's part of general workup. Of course, renal sonogram, and then you have the serologist there. But that mostly will be for the either primary physician or the kidney doctor to rule out other causes. However, sometimes keep in mind, the reason why I bring this up in terms of doing some of the serologies is because perhaps in the Caucasian population, one of the most common or faster HIV-associated diseases is glomerulonephritis. Since HIV is a chronic condition, your immune system is trying to fight it off. You make a lot of antibodies trying to fight off the infection. Many antibodies, they precipitate in the kidney. The kidney receives 1/5 of the blood flow at all the times. So all this constant exposure to antigen antibody will activate the complement pathway and cause inflammation. So sometimes it's not the HIV per se causing direct damage, it's just the effect of it from the immune system.
This is like, I guess, happens in the cardiovascular system, the HIV, or the brain.
Correct, the inflammation, exactly. Any type of inflammation will accelerate atherosclerosis, and that's why there's some evidence that that's part of the reason why they have higher, the incidence of heart disease is increasing in this population, same with strokes. So that's a very good argument. For example, conditions like lupus or rheumatoid arthritis have a higher amount of heart disease compared to a healthy population because of the high inflammation. Sometimes in those situations, if it's a glomerulonephritis, we talk to you guys to see if it would be prudent to give a course, like a month or so, of steroids, corticosteroids, trying to calm down with the inflammation. And we have done it in a couple of cases with basically controlling the disease in situations in which we felt that the progression of the kidney disease was going to add too much comorbidity and decrease expectancy of the patient. And overall, of course, when we see kidney disease, and in HIV, the most common causes in terms of acute renal failure are basically the same reasons that you get acute renal failure in the non-HIV population. So like dehydration, hypotension, obstruction, those things, or the patient is severely septic. Those things are going to be the most common causes. Use of construct dye, in high-risk patients, also is another factor. The take-home message from this one would be sometimes, for example, in the case of obstruction, is it like some medications? Atazanavir, we all know about Indinavir. But atazanavir can cause kidney stones. We had that 2 years ago. This gentleman having recurrent stones. They send them for analysis, seeing infrared something, and they saw the drug. Atazanavir, and so sometimes some particular drugs can cause it. In theory, many drugs can do it. Not only that one, any type of drug can precipitate. And the key to that is good hydration. Another one from this list that I forgot to mention, which is actually not uncommon in this population, is interstitial nephritis. Sometimes we don't know the mechanism. These patients may have a more tendency to develop a reaction to these medications. Some of these medications can cause rash and what have you, and reactions in the body. They sometimes only manifest in the kidneys. So we have seen a couple of cases as well of interstitial nephritis in HIV patients. Either from, we suspect some of the antiretrovirals, but sometimes that's hard to prove, or some of the other drugs sometimes if they are on prophylaxis with Septra or things of that nature. Those are hard to manage sometimes because the biopsy looks the same no matter what the offending agent is, and sometimes you have to go one by one with time. And re-challenge to see if that was the case or not. These are a chart basically telling you, summarizing what I mentioned before. As you can see, in the obstruction, the Indinavir, Atazanavir, sulfa drugs can cause crystals. Penicillins can cause crystals. Acyclovir can also crystallize. The main management is basically adequate hydration before you start the patients in these medications, hopefully. One dose is not going to do it, but at least assure of that. And the allergies that have been interstitial nephritis, Indinavir has also has been some several case report causing interstitial nephritis as well. And when talking about specific diseases, we have the HIVAN with HIV, which is HIV-associated nephropathy, African American preference. These individuals, their GFR, their kidney function declines very fast. So, basically the take-home message from this is, if you see a patient that is having acute renal failure, and you see protein in the urine, a significant amount of protein, don't hesitate to order the HIV. Don't think your attending is going to go crazy or what have you. It is a very legit, and it can be treated. Not because in the past sometimes that used to be more of a diagnosis of exclusion. You wait until everything else is done. That doesn't mean you still do everything else. Like the ultrasound, whatever. All these other things to make sure. But also, it's not prudent, especially if you think this person has high risk behaviors, to incorporate that into as part of the workup. Basically, we do basically in every patient that we see. And but it's mostly for the fellow. I mean, how it looks in the biopsy. Hopefully, you don't get a picture like that in your board. That'd be kind of unfair. This is normal, and this is bad. I mean, hopefully that would be unfair. I mean, yeah, yeah. Well, let's try. I mean, for sake of examination, exactly, most likely, as this is the one that gets the most attention, I mean, the one that perhaps is the fastest decline in GFR. Even if you happen to get a question like this, the answer is going to be high one. I mean, HIV-associated nephropathy. Yes, that's a good way to put it. You mentioned earlier, Pamela, that what about ACE inhibitors? And it's true. As part of the HIV-associated nephropathy, you can use ACE inhibitors, absolutely. There are some studies that show that definitely holds the progression of the condition. Before the availability of antiretrovirals as a full triple regimen that you guys use today, that was basically the only drug that was out there. And of course, with the retrovirals, you're adding years. With these ACE inhibitors only, you were adding maybe a few months. I mean, of course, that's better than zero, but it is part of the whole cocktail of medications in order that it will help stabilize kidney function. But still, you must get the patient antiretrovirals. That's the number one. And steroids can be used for a couple of months. We did use them in this guy, which I presented you at the beginning of the lecture, until the antiretrovirals get the full effect. The steroids are good to mitigate that immune reaction, because by definition, if you hear the word glomerulonephritis, that means inflammation. Basically, if you read that section, most of the treatment is actually some type of medication to tone down the immune system, as from overreacting. I mean, so that will give you time until other medications takes time to work fully. And now we're seeing a lot of these things, these HIV-associated other glomerulonephritis or immune complex diseases. We have seen a couple of IgAs in the hospital, and from Tampa General, they see like lupus-like. Amyloid is mostly described in the literature. I never seen it. I mean, but any type of chronic condition can cause secondary amyloidosis. In general, perhaps besides the IgA, which steroids, I mean, seems to at least do some benefit, these other ones are very hard to manage, and we'll be having a trouble when sometimes we get a consult already been diagnosed in some other hospital with any of these other conditions, and the patient's already controlled on HIV, maybe already a trial of steroids have been done, and still there's a progression of the disease. Unfortunately, sometimes we don't have a particular medication to control the immune system. We're exactly where we want to. I mean, of course, they're doing studies to see which cytokines are most active, or which interleukin, or what have you, and you try to target. But unfortunately, there's no evidence, or there are no studies in this area as of yet.
They haven't tried any
Yes, we have tried azathioprine, cyclophosphamide, Cellset, mycophenolate, and actually the problem is we're a little bit, honestly, a little bit hesitant sometimes of starting a little bit stronger immune suppressant medications in these individuals.
But let me tell you something. Now they're doing
The transplant.
transplants in HIV patients, and now we have one patient that had an allo transplant here in HIV. Not
Wow.
allo, but allo.
Wow.
Yeah. Right? We got him. Unfortunately, he relapsed.
Oh.
But
Yeah. But he's on immune suppression here.
HIV is doing good.
No, exactly. With that evidence, especially there's a lot of kidney transplant is also part of the treatment. The kidneys fail in these patients. We have a couple in the VA Now they're accepting for these patients to be transplanted. They already are on mycophenolate, they're already on tacrolimus. So the fear of using these medications to treat these other entities is becoming less. It's just unfortunately, like nowadays, everything is evidence-based. I mean, so sometimes it's hard to convince the institution and anything else in between, because obviously it's a little bit of area of unknown. I mean, and actually that patient that I mentioned that had the high band despite the HIV being well controlled, that's another thought. Can we try maybe mycophenolate to come down with immune function? We're still discussing it because he's doing so well that it's kind of like a really difficult choice. I mean, in the unknown. But we're talking with him like every couple of months or so. I mean, kidney function is still fairly stable, so I think there's time to come up with a good plan. And then this table basically summarizes all the possibilities that can be associated with HIV. Basically everything. I mean, so it makes it very interesting for us because I mean, when we biopsy these patients, we really don't know. I mean, what we're gonna see. I mean, so however, that's something else that I like to stress, that is, we are biopsying these individuals more. At one point, since there was not much to offer, and the stigma with HIV, there was some reluctancy to do that. I mean, now more and more, these patients we're biopsying because in many cases we can change management, and actually in many cases are actually is actually interstitial nephritis, which just by removing an offending agent, so perhaps it's short course steroids, can really bring these patients' GFR to a more better level. Oh. And then this with the thrombomicroangiopathy, really, you know, that's neither myself nor my colleagues have ever seen this. I mean, that was probably a long time ago in the late 90s. It can cause direct damage to endothelial cells, but even in here, they haven't seen it with relationship to HIV. I asked Dr. Lopez and these guys here. So most likely, it's just nice to know, but not really high yield. And the immune reconstitution syndrome, that's something to keep an eye on. When you start these medications, the immune system does become activated. We have seen definitely, we have a patient that had a little RBCs in the urine. He had HIV, was none already. At that time, however, because his CD4 count was in the 500s, Baralo was maybe 50 or 60. The indication, you know, was that was in 08. The indication was like, you know, maybe wait. Plus, the guy was not the most compliant patient, you know, in other things. However, he developed a Hodgkin's, and therefore, because he had a AIDS-defining illness, he was given the heart.
And his CD4 was very high.
CD4 was very high. I mean, it was normal.
Time,
yeah.
The guidelines did not recommend to start. I mean, now there are some recommendations to start HIV treatment on patients depending on the CD4. One of them is HIV-associated. Back then, that indication was not there. So that's why the patient was not started.
Before, exactly.
So he got lucky that he got lymphoma.
In a way, he got lucky, but then he got treated with the heart, and his renal function just collapsed. He had a massive glomerulonephritis, or rapid progressive glomerulonephritis. Basically, it was an immune reconstitution of his system. He had already perhaps a little bit of glomerulonephritis from his HIV. His HIV gets treated, the immune system improves significantly, and you can see the biopsy here. These are crescents. I mean, cadmium up to 10, and he got treated with Cytoxan. I mean, so this is one of the cases in which we did that, and he came off dialysis. He's been off dialysis in the last 5 years. I mean, he has some residual damage, so over time, progressively, his GFR is decreasing, but still, he's not on dialysis. He's doing very, very stable. I mean, otherwise. So, to answer your question before, sometimes we do use his regimens. Unfortunately, it's like when there's like a crisis. It's like when we start going away. And this interstitial nephritis is a quick word. To see this fever, rash, and eosinophilia, I mean, if you see that, good for you. That never happens, all of them at the same time. Actually, most common, actually, you find nothing. I mean, normal UA, patient feels well, no fevers, nothing. That's the most common finding, actually. And that's why you have to think about it. Otherwise, you will never even suspect this. I mean, the thing why you make us memorize this trial, because the paper started in 1920 with penicillin, and not penicillin, I think it was one of the sulfa drugs. I forgot the name of the... He was a pathologist, or one of the first few pathologists that put it on the slide, and he discovered this entity. And ever since then, they teach it like that. But in reality, it's not, you don't see... If you see it, great. I mean, but if you don't see it, don't mean that person doesn't have it. Yeah. There's an excellent slide. I mean, those are the medications that can cause most associated with HIN. I mean, with AIN. Actually, maybe it's not such a bad thing, because in reality, that's blurry, because it means anything could do it. I mean, but really, quinolones, antibiotics like beta-lactams, the quinolones, the sulfa, rifampin. One of the most common ones lately is omeprazole. A lot of case reports on that. So really, for that argument, could be any drug. Even that's an outpatient drug. I mean, meaning can get over the counter. I mean, so you have to keep always ask patients. We always have to ask the patients if there's anything to take over the counter, supplements, herbal, products. I mean, these other things, and you'll be amazed that sometimes we just remove those agents without doing the biopsy, and things return to baseline. You can give a course of antibiotics, of steroids for the AIN. Crystals, we talked about it, with basically atazanavir being one of the newer ones that you may see in your testing. Indinavir, of course, is like in every internal medicine board. And probably be there forever. And then, it's a little bit on tenofovir. The reason, let me show here this, why we speculate it can cause kidney disease. These are transporters that can get the medication into the proximal tubular cell. And then these are transporters that will get it into the urine. If you have other medications that compete with these same transporters, this is known as organic anion transporter. And these are the multiple drug resistant protein transporter. If you have multiple medications that use the same pathway, what ends up happening then, the tenofovir within the proximal cell, concentration gets high. Of course, this inhibits DNA. I mean, the DNA that is most exposed is a mitochondrial DNA, it's a circular DNA. So the medication gets in there, inhibits the DNA from obviously replicating and what have you. And if your mitochondria dies, say goodbye to your cell. I mean, so that's how this is the mechanism of what happens with tenofovir. Initially, it's not like one cell. I mean, it's not like all of the cells will die at the same time. Some of them are more resistant than others, and what have you. So sometimes that's why you see some of the other findings first, like low phosphorus, but that means then the proximal cell is kind of weaker. Maybe the ones that are more involved in reabsorbing the phosphorus are the ones that are affected first, and you see them. So sometimes before you see the full-blown acute tubular necrosis, in which the majority or a big number of the tubular cells are significantly damaged, you see some partial damage. Manifestaries are low phosphorus, acidosis, or glucose in the urine, like Fanconi syndrome. So basically, Fanconi syndrome or a partial Fanconi will be the initial hallmark of tenofovir toxicity. There have been also many case reports in which sometimes, unfortunately, the patient just young patients I'm talking about, show up with just fractures, and then after the fracture they do workup and they see the phosphorus is like very, very low. I mean, so there was a lot of loss of bone turnover.
And you know, tenofovir is the one antiretroviral that is associated with osteopenia.
It could be that the theory, because phosphorus is lost significantly, and unfortunately phosphorus is not part of the basic metabolic profile. So when you don't see it there, unfortunately, out of sight, out of mind. I mean, and so once in a while, the recommendation is, at least every 6 months or at least once a year to measure the phosphorus. I mean, it's not like you're gonna see this change that fast. So in our literature, it's like at least once a year we do it. Yeah. And so this is what I was talking about. But the key always in all of these patients, please estimate the GFR constantly, because sometimes that's the answer, just adjusting the medication, and that's it. Or if you have like somewhat of a question, like, it's maybe hard, then send it to us or call me or any of us. We can help you more or less have an estimate of the GFR. There are other molecules now like cystatin C, which we can incorporate into the formula. We do sometimes 24-hour creatinine and urea clearance and take average from those. Other ways to estimate the true GFR. The true GFR, if you do it like one of those iothalamates or whatever that you read in books, but good luck if you find somebody that does that. They'll do it. It just, that's very expensive and really doesn't matter. When there have been we have studies like using the creatinine clearance and what have you. In terms of outcomes, we don't really need to be so exact as to what's a true GFR. We just need to know what the trend is and more or less where the patient falls. And in here, actually, the IAC recommends, this monitoring actually in biannual basis. Actually, I forgot about that. In their guidelines, so they do put it there. And these are just some of the medications, but this stuff, what that means, really any drug can be associated with kidney disease. So when we see a patient personally with acute kidney disease and who has HIV, we go through each of their medications. Some of them have more incidence than others, when looking back as causing kidney disease, but in reality any of them could. And in cases in which we have basically excludes everything else, then we will ask the ID expert to see, could we try some other regimen? Maybe that's what's causing it. On occasion that has happened. And then these are just antibiotics that can cause kidney disease, but that it's just because it happens to be used perhaps more in opportunistic infections. But you guys are aware of this. And just a quick slide to end. Basically, especially this last part here. These patients are basically becoming the bread and butter patient, the hypertension, the diabetes. So now it turns to be like perhaps what determines the actual longevity and the actual, for sake of their quality of life, is treating their chronic, other now more common chronic conditions, which if sometimes can be a challenge. In these patients, especially because so many medications. But that's basically is what's becoming the trend right now. Okay, any questions? Okay. And just a quick word, we can transplant these patients, and it requires a very good. Obviously, patient has to be well controlled, viral load more than 200, zero CD4 count more than 200, at least no opportunities infection like for the last previous 6 months. Those are the general rules to qualify for the evaluation for transplantation. And it's important to have a very good team. In this case, the pharmacist becomes a very important part of the member because of the interactions. And we have like a partial time. What do you call it? Partial time or pharmacist? Not full time. Part time. Yeah. And some of those problems, I just call her and say, deal with this because it can take forever. I mean, to look at all those interactions. Okie dokie. So good night to the podcast people.